Hello, my name is Catherine Varner. I'm an emergency physician and clinician scientist at Mount Sinai Hospital in Toronto. Today I'm presenting our study entitled Predictors of Post-Concussion Syndrome in Acute Mild Traumatic Brain Injury in the Emergency Department. My co-authors and I have no conflicts of interest to disclose. I'm currently funded by the University of Toronto Department of Family and Community Medicine, as well as the Schwartz-Reisman Emergency Medicine Institute at Mount Sinai Hospital. Funding for this trial was provided by the Workers' Safety and Insurance Board of Ontario, as well as the Canadian Association of Emergency Physicians. The emergency department is the first point of healthcare contact for most head-injured patients, yet the majority of these patients will not have an intracranial injury but will ultimately be diagnosed with a mild traumatic brain injury, also known as concussion. Most patients will have a full symptom recovery within 7 days. However, 15 to 30% will go on to develop post-concussion syndrome. Post-concussion syndrome usually peaks at around 4 to 6 weeks after injury, but upwards of 20% of patients will not have returned to work at a year after their initial visit from the emergency department. Despite the frequency of mild traumatic brain injury and the disability associated with post-concussion syndrome, validated tools do not yet exist to determine who is at risk of a prolonged recovery. Thus, there is an urgent need to describe clinical predictors that accurately identify adult patients at risk for post-concussion syndrome early in their injury, which might allow for early provision of management strategies to circumvent ongoing problems. The objective of this study was to identify risk factors independently associated with post-concussion syndrome at 30 days in adults presenting to the emergency department with an acute mild traumatic brain injury. This was a secondary analysis of a randomized control trial conducted from June 2017 to October 2019 in 3 academic Canadian emergency departments, evaluating prescribed light exercise to standard care for patients presenting with a mild traumatic brain injury. Participants were enrolled in the following emergency departments: Mount Sinai Hospital in Toronto, Ontario, Hamilton General Hospital, and Juravinski Hospital, both in Hamilton. All 3 hospitals are academic hospitals affiliated with University of Toronto and McMaster University, respectively, and have annual visits between 45,000 to 65,000 visits per site. The research ethics boards of all institutions approved the study protocol, and the trial was registered with clinicaltrials.gov. All adult patients presenting to the emergency department with a mild traumatic brain injury sustained within the preceding 48 hours were eligible for trial enrollment. Acute mild traumatic brain injury was defined by the Zurich Consensus Statement. Exclusion criteria are listed here. Diagnosis of mild traumatic brain injury and determination of trial eligibility were by the attending emergency physician. Informed written consent was obtained from trained research personnel when they were available, or by the attending physician or nurse if it was out of hours. Participants were followed at 7, 14, and 30 days. The majority completed follow-up questionnaires online. One strategy that was helpful for this youthful cohort included text message reminders. Participants received text messages if their survey responses were delayed, which was completed as a separate part of the consent process. Participants were, however, considered lost to follow-up 3 days after the follow-up time period. The primary outcome was the presence of post-concussion syndrome, defined as the presence of 3 or more symptoms with a score of at least 2 corresponding to a moderate problem on the River-Mead Post-Concussion Symptom Questionnaire at 30 days. The RPQ is a 16-item questionnaire which asks patients to rate the severity of the most common PCS symptoms on a scale of 0 to 4 and was chosen because of its consistency, good construct validity, sensitivity of self-reported recovery status up to 6 months post-head injury, and has been used in previous studies assessing patients with PCS. All baseline symptoms were treated as binary variables. Proportional differences were assessed using chi-square statistics with 95% confidence intervals. Candidate predictors were selected based on known or hypothesized associations with PCS, and univariable analyses were used to determine the strength of association between each variable and primary outcome. Backward stepwise multivariable logistic regression with a removal criterion probability of 0.05 was conducted to determine predictor variables independently associated with PCS at 30 days. Likelihood ratio tests were used to determine the appropriate inclusion of the variables in the multivariable model. Model calibration was assessed using the Hosmer-Limichal goodness of fit statistic, and model discrimination was assessed by examining the area under the receiver operating characteristic curve. A total of 367 patients were enrolled in the trial. After removing those who withdrew from the study and those who were lost to follow-up, there were 241 patients included in the analysis. Of the 241 patients who completed follow-up at 30 days, their median age was 33 years and 61% were female. In this general ED cohort, only 8% of these injuries were sports-related. 17% of participants underwent head CT, and at the time of ED assessment, the median RPQ was 15, which corresponds to moderate head injury symptoms. Clinical features of this cohort are described in this table. Notably, 13% of patients lost consciousness at the time of the injury, 19 reported amnesia around the injury, and 86% had a headache in the emergency department. Roughly 30% of participants had history of anxiety or depression, 30% had a history of concussion, and 19% had a history of regular headaches. At 30 days, 20% had post-concussion syndrome. Additionally, 71% of participants had missed school or work for mild traumatic brain injury symptoms. 11% had an unplanned return visit to the emergency department, and 60% had a head injury-related visit to any healthcare provider within the 30 days after the ED visit. Listed are the characteristics included in the multivariable model based on their strength of association with PCS described in the univariate analyses. Headache at emergency department presentation, being under the influence of drugs or alcohol at the time of injury, the injury occurring via bike or motor vehicle collision, history of anxiety or depression, and the sensation of numbness or tingling at ED presentation were independently associated with post-concussion syndrome at 30 days. The model achieved good discrimination with an area under the receiver operating characteristic curve of 0.73, and the Hosmer-Limichal goodness of fit statistic was 14.28, indicating that the model was well fit to the data. Participants with higher baseline Rivermead post-concussion symptom questionnaire scores were also shown to have higher prevalence of post-concussion syndrome at 30 days. We acknowledge that this study has several limitations. First, it was conducted in a small number of urban and academically affiliated emergency departments that were also Canadian, and this may impact the generalizability of the results. We also had a high rate of attrition, which is commonly seen in studies of this patient population. Most patients in our cohort presented with moderate head injury symptoms, potentially suggesting we were enrolling lower acuity mild traumatic brain injury patients. However, we believe the enrolled patients are representative of the typical mild traumatic brain injury patients presenting to most EDs. Our primary outcome used the Rivermead post-concussion symptom questionnaire, which is self-reported and it's also subjective. However, the RPQ was chosen because of its consistency, good constructability, and being sensitive to self-reported recovery status up to 6 months following head injury. Finally, the study identified individual risk factors independently associated with PCS at 30 days, but no external validation was performed. In summary, this study found 1 in 5 patients presenting to the emergency department and diagnosed with an acute mild traumatic brain injury went on to have post-concussion syndrome 1 month after their injury. 5 variables were independently associated with post-concussion syndrome, including headache at the emergency department presentation, being under the influence of drugs or alcohol at the time of injury, the injury occurring via bike or motor vehicle collision, history of anxiety or depression, and the sensation of numbness or tingling at the emergency department presentation. Patients with these risk factors should be considered high risk and flagged for early follow-up. Future studies are needed to create validated and pragmatic tools to help identify adults at risk of developing post-concussion syndrome. I just want to finish up by saying thank you to my co-investigators who put a lot of work into this trial, and thank you to SAME for this opportunity to present, albeit virtually. And I wish you all well, and please stay well amidst the COVID-19 pandemic.